Hi, thank you for allowing me to present this work. Thank you. I have no disclosure. So as we know, obesity is becoming a great public health issue in both in Canada, US, and worldwide. It is associated with increased rates of diabetes, hypertension, which are themselves associated with the increased risk of chronic kidney disease. So obese patients, in addition to having the similar restriction to organs as other general population of end-stage renal disease patient, may be prevented from being listed given their weight. In Canada, a recent survey showed that 80% of transplant surgeons were using BMI as a cutoff to limit access, with various values being used, and that only 30% of the centers in Canada had weight management program associated with their kidney transplant programs, and that bariatric surgery was used sparingly. However, we know in the general population that bariatric surgery is highly efficient for resolution of comorbidities and improvement in obesity, and therefore in our center we started doing sleeve gastrectomy for pre-transplant patient with the following inclusions. So the objective of this study is to review our experience with sleeve gastrectomy as a strategy to improve rate of kidney transplantation. So this is a retrospective case series. We're looking at our transplant database and our bariatric surgery database. Patients were included if they had a BMI 35 and above or metabolic syndrome with increased waist circumference. These were all patients with severe CKD, stage 4 and stage 5, that were evaluated by the transplant clinic, and then underwent a sleeve gastrectomy between 2013 and 2018. We excluded patients who had prior bariatric surgery. So the outcomes we're looking at are the 90-day complications post-sleeve gastrectomy, and also weight loss and outcome regarding kidney transplantation. We are not doing any inference given a small number. So we were able to identify 32 patients in this subpopulation, which were mostly male and age 51 years old median. The initial weight, the initial BMI prior to the sleeve gastrectomy was 42, and they were mostly all on dialysis, with 29 out of them, mostly hemodialysis. Several of them, unsurprisingly, had diabetes, hypertension, dyslipidemia, and obstructive sleep apnea. This is the distribution of the primary etiology of their kidney disease. As we can notice, a significant amount of those patients had diabetes type 2 and other disease related to metabolic syndrome as their cause of their chronic kidney disease. The median follow-up of our cohort was 14 months post-sleeve gastrectomy. In the 90-day postoperative period, we identified a single complication being a readmission for hydration on the post-op day 4. On the longer outcomes, we had a single patient with severe reflux disease post-sleeve gastrectomy that improved with the medical management and did not require conversion to Roux-en-Y. This is the progression of the weight of our cohort. So at 1 year, the estimated weight loss percentage was 56, with that corresponded to a change in BMI roughly of 10 kilogram per meter square, and which can also be expressed as a total, like as a median weight loss of 29 kilos. As we can see also on the longer term follow-up, this seems to be good weight maintenance. However, the number of patients are quite smaller. So in this cohort, 44% of the patients underwent successful renal transplant after the sleeve gastrectomy. This was done at a median interval of 8 months post-sleeve gastrectomy, and at that point, their BMI was at a median of 31. There was a single mortality described in this cohort, which occurred 28 months post-sleeve gastrectomy on a patient that was listed. There were 2 acute rejections from the kidney transplantation that were both responded and required pulse steroids. And at the median follow-up of 9 months post-transplant, there were no return to dialysis for graft loss. However, this is quite a short follow-up to assess. So this is one of the latest case series that is available on the subject. we were quite pleased with confirming that our complication rate were similar to the general population based on already published data. The other positive point was also that we were surprised on the high number of patients that actually underwent kidney transplantation. Several limitations to the study. Lack of comparison group is the biggest one. We would like to compare our cohort to patients who did not undergo sleeve gastrectomy with similar BMIs, or that compare our complication rate to our general population. This is also single center. So in conclusion, sleeve gastrectomy appears to be a safe way and an effective way to increase transplantation rate in a morbidly obese patient with chronic kidney disease, and further research is needed on the subject. Thank you. I'll be happy to take questions.
Great.